So today we will be starting a new chapter, testis and scrotum. This is a very important chapter for you people, because most of the conditions that you are seeing in general surgery department are from this chapter, hernia, hydrocele, etc. And because of examination point of view also, you should know in detail everything in this chapter. To understand the conditions of the testis and scrotum, it is essential for us to have a clear idea about the anatomy and especially the embryological development of the testis. Unless we have insights into the embryological development of testis and scrotum, we will not be able to appreciate the pathogenesis of many of the diseases affecting these organs. Testis develops in the retroperitoneum at the level of 10th thoracic vertebra, just below the developing kidney. It first appears in the latter half of the second month of fetal life. That is around the 7th week of gestation. At around the same time, an elongated mesenchymal structure called gubernaculum develops within the folds of the peritoneum inside the abdomen. And the upper end of this gubernaculum will be attached to the developing testis, and the lower end of this gubernaculum will be attached to the fascia between the developing abdominal wall muscles near the groin region. So the testis, which initially appears present inside the abdomen retroperitoneally, just below the developing kidney, traverses all the way downwards and reaches its final destination in the scrotum, bottom of the scrotum, just before the birth. The gubernaculum probably helps, which contains muscle fibers, probably helps in the final descent of the testis from the external ring of the inguinal canal to the bottom of the scrotum. Other than that, we don't know the exact role it plays in its descent. Probably maternal chorionic gonadotropin and also anti-Mullerian hormone may play a part in the descent of testis and its development. Let us go graphically and understand this much more clearly. This is the cross section of the part of the abdominal wall. So you can see the muscles here, the peritoneum here. This is the peritoneum, this is the retroperitoneal region, and this is the transversalis fascia. And above that is the transversus abdominis muscle, and superficial to that is internal oblique muscle. Then externally there is external oblique muscle and skin and fascia and skin. So these are the cross section. So in the retroperitoneum, inside the abdomen, the testis develops and the gubernaculum attaches to the lower end of the testis and also to the fascia between those muscles. what we know is the testis is at the level of internal ring at 3 months of gestation. At 3 months of gestation, it descends up to the level of future internal ring of the inguinal canal. As you know, inguinal canal has got internal ring and external ring. In between there is a canal. So at 3 months of age of the fetus, it is at the level of internal ring. And later, in another 5 to 6 months, that is between 7 and 9 months, it reaches the bottom of the scrotum. So the final descent from the external ring of the inguinal canal to the bottom of the scrotum takes place within the final 4 to 6 weeks. See, for this to happen, there should be an opening. See, initially there is no inguinal canal itself. So what actually happens is, adjacent to this gubernaculum, this peritoneum evaginates. It evaginates into a process. We call that process as processus vaginalis. See, this peritoneal process evaginates and makes a canal. When it passes through the abdominal wall completely and forms a outpouching, we call it scrotum. So this processus vaginalis facilitates, when it evaginates outside, it also takes the gubernaculum and testis through the canal. See, by this you can understand the scrotum has got components of all the layers of the abdominal wall represented in its layers. The processus vaginalis, as you can see, it is a peritoneal process. So this processus vaginalis eventually when the testis becomes intrascrotal location, invests all the sides of testis except the posterior side. So there are 2 layers of this processus vaginalis. We call them tunica vaginalis when it completely invests as a tunica. And from the upper pole of the testis, the remaining processus vaginalis obliterates completely. So only around the testis there are 2 layers of peritoneum. We call it tunica vaginalis, testis, and one layer is intimately connected with the tunica albuginea, that is the outer tough layer of the testis. The other is parietal layer. Between this parietal layer and visceral layer of tunica vaginalis, there is a potential space. Except for that, the remaining processus vaginalis completely obliterates. And as I was telling you, there are components of abdominal wall muscle which becomes layered to the scrotum because of this process. We'll see it a little more clearly. See, it's a better illustration. So this is the processus vaginalis I'm telling you. And then there is transversalis fascia. Transversalis fascia forms all round, and in the scrotum we call this component of transversalis fascia as internal spermatic fascia. So superficial to that, internal oblique component of the scrotal layer comes. See, internal oblique also forms in the inguinal canal the cremastre muscle. It gives a muscle, some muscle fascicles around the cord in the inguinal canal. We call that cremastre muscle. And beyond the external ring of the inguinal canal, it will be a fascia. We call that cremastric fascia. another layer of the scrotum. Then external to that superficial to internal oblique, there is a external oblique, and external oblique aponeurosis also gives a layer of tissue around the scrotum. That we call it external spermatic fascia, and the remaining is a subcutaneous tissue and fascia and the skin of the scrotum. See, this is how the scrotum and the testis descent and development takes place. And we should understand all these changes to understand many of the diseases which we are going to talk about a little later. So let us see. See, as a consequence of intra-abdominal development of the testis, it derives its blood supply, nerve supply, and lymphatic supply, everything from abdominal region. Because initially it was an intra-abdominal structure, even though it reaches the bottom of the scrotum, it gets all its blood supply, lymphatic supply, and nerve supply from the abdomen. The testicular arteries, the main blood supply to the testis, arises from the abdominal aorta just below the renal arteries. I was telling you that testis develops just below the kidneys. That's why the blood supply comes from the abdominal aorta below the level of renal arteries. And again the renal vein, the testicular veins. See, testicular veins, they start from, the drainage starts from the testis, and there are multiple tributaries. And these multiple tributaries, they pass upwards. We call them pampiniform plexus. See, these pampiniform plexus, which are tributaries draining the venous tributaries draining the testis, as they go up, they join together and anastomose with each other and join together into lesser and lesser number of veins, and ultimately at the inguinal ring there will be only one or two testicular veins, and they ascend in the retroperitoneum. On the right side they enter the inferior vena cava. On the left side the testicular vein enters the left renal vein. See, this is an important thing. Left side it drains into the left renal vein, but the right testicular vein drains into the inferior vena cava. And of course, again, the lymphatics from the testis will drain into the para-aortic lymph nodes in the abdomen. And coming to the testicular structure itself, testis is covered by a thick, tough outer covering. We call it tunica albuginea. Within the tunica albuginea, there is seminiferous tubules, and they are compartmentalized by the septae. And in between them, there is seminiferous tubules. See, at the hilum of the testis, there is vas efferentia which join the epididymis. The epididymis lies posterior to the testis. In the upper pole, the epididymis is divided into a body, head, body, and tail. See, the tail comes up to the lower pole of the testis. So the spermatozoa, they travel from these ductules and enter the head of the epididymis. Later they pass to the body of the epididymis and go down into the tail of the epididymis at the lower pole of the testis. From the lower pole arises the vas deferens, which curls upwards and goes to the upper pole, and then it goes to the inguinal canal and intra-abdominally, retroperitoneally to reach the seminal vesicles. So during its ascent, this mass difference can be easily be palpable at the upper pole of the testis as a cord-like structure. So while it is passing through the inguinal canal, it is invested by the pampiniform plexus and is accompanied by other structures like the testicular artery, then the lymphatics and all those things. So this particular anatomical arrangement, you should always be very clear to understand some of the diseases which you are going to talk. So now coming to the diseases affecting the testis, let us talk about the condition undescended testis. For some boys, about 4% of the boys, the testis does not descend into the scrotum at birth. About 4% of the people, boys, may not have the testis in the scrotum, and its descent might have been arrested at some level higher up. See, what is called undescended testis is when the testis descent is arrested in some part of its normal path of the scrotum, it is called undescended testis. But if the testis does descend through its normal path but does not reach the scrotum and it reaches a different location, it is called ectopic testis. So ectopic testis is when it is abnormally placed outside its normal path. So there are two different conditions, undescended testis and ectopic testis. Ectopic testis is very, very rare. Undescended testis 4% at birth, but many of these undescended testes which we noticed at birth may reach the bottom of the scrotum within 3 months after the birth. So within 3 months after the birth of the child, many of these undescended testes will descend into the bottom of the scrotum. So if you take the incidence at 1 year of age of the kid, it is only 1%, not 4%, because many of them they reach within 3 months after the birth. After the 3 months of the birth, it's very, very unlikely they reach the bottom of the scrotum. So in 10% of unilateral undescended testis, there is a family history of undescended testis. Many of these undescended testis Okay, so let's understand the actual pathology of undescended testis. It's more common on the right side. At 20% cases, both the testes will be undescended. So 20% are bilateral and more common on the right side if it's unilateral. Undescended testis itself does not cause any abnormalities in the secondary sexual characteristics. So secondary sexual characteristics of the boy will be normal even in undescended testis. The testis can arrest in its descent intra-abdominally or in the inguinal canal or outside the inguinal canal. In the intra-abdominal arrest, usually the common location is it is arrested at the just proximal to the internal ring of the inguinal canal. That's the location. So retroperitoneally at the level of proximal to the internal ring of the inguinal canal, it gets arrested. So outside, in the canalicular arrest of the testes, it will be in the inguinal canal. Usually it can be palpable or may not be palpable sometimes. Many times you can just palpate the testes in the inguinal canal, but sometimes it may not also. So outside the inguinal canal, it usually is located just distal to the external ring of the inguinal canal, that is at the root of the scrotum, upper part of the scrotum. When it is ectopic, it comes out the external ring normally in its normal path, but it doesn't reach the scrotum. The commonest ectopic location is superficial inguinal pouch. See, superficial inguinal pouch is just inferior and lateral to the external ring. So that's the location where it is ectopically present sometimes in subcutaneous area. So it can also reach the femoral triangle also by the thigh, or sometimes it is present at the root of the scrotum or even perineum, though they are very, very rare. So these are all the positions the undescended testes can be found, and ectopic testes are found. If you see and palpate the undescended testes, usually it will be of the same size as the other descended testes before the onset of puberty. So externally, macroscopically, there are not much changes between the descended and the undescended testes as far as the size is concerned. But after puberty or around puberty, the normal testis develops into normal and growth. But undescended testis, usually it will be smaller in size, and also it may be softer than the normally descended testis. So macroscopic changes do occur around the time of puberty. And histologically, if you take, the changes are much earlier. See, within 1 to 2 years of the postnatal life, there will be changes in the undescended testes microscopically. What are these changes? These changes are loss of the Leydig cells and degeneration of the Sertoli cells, and also decreased spermatogenesis. These are the changes that takes place. So the Leydig cells and Sertoli cells are the supporting cells. Leydig cells function in producing the testosterone, and the Sertoli cells, the function is to support nutritionally the developing spermatogonia. So both these cells, there will be degeneration which starts from first year of the baby onwards. So this is a very important thing that you have to remember. What are the complications that can be caused by the undescended testes? See, undescended testes, it is normal testes, usually normally developed testes, definitely it reaches the scrotum. But if there is developmental abnormality and it is undescended, so consequently there will be infertility. If you see the fertility of the people of persons with undescended testes, unilateral undescended testes, the paternity rates is 2/3 of the normal. So they are not perfectly normal, only 2/3 of the normal people. But when bilateral undescended testes, if they are having, so the fertility rate drops down to 1/3 of the normal. So there is a decreased fertility in case of patients with undescended testes. That's one complication. And they're also prone for malignancy. See, the testes, is 5 to 10 times more likely to become malignant in their lifetime than the normal people. And when malignancy does occur, it will be usually seminoma. See, there are so many types of malignancies which we'll be discussing when we discuss about testicular tumors. So seminoma is one of the types of malignancies of testes, and they develop seminoma in undescended testes, which is 5 to 10 times more common than the normal people. You see, most of these cases of undescended testes, they have associated patent processus vaginalis. I was telling you, processus vaginalis will get obliterated normally from the level of the upper pole of the scrotum to the peritoneum. It gets completely obliterated. But some people it persists, and especially in undescended testis patients, it persists up to 90% of the people. So, persistence of processus vaginalis can be predisposes to hernia formation. You will know about these when we discuss about the hernias also. So, patent processus vaginalis, a bowel can just herniate through that, and then hernia formation occurs, indirect inguinal hernia. So these people are prone to, 90% of the time, prone to have hernia. But all the 90% people who have this persistent processus vaginalis will not develop hernia. Definitely, quite considerable number of people will have hernia. Okay, so the testis abnormally located is more prone for testicular torsion. Testicular torsion is a condition which we will discuss in detail a little later. So testicular torsion is a twisting of the testis, causing twisting of its vascular supply and then occlusion of the vascular supply and necrosis. So that condition occurs more likely in the undescended testis. Again, this is due to, see, normally descended testis is at the bottom of the scrotum is well fixed. It's unlikely to have a torsion. But because here there is developmental abnormality, abnormal fixation occurs, and the testicular torsion is more likely to occur. So these are all the complications: infertility, malignancy, hernia formation, and testicular torsion. All four are complications that are likely to occur in undescended testis. What are the clinical features? If the infant neonate is examined properly, it is not easy to miss an undescended testis. But you have to differentiate this condition from retractile testis. Normally, young boys, the cremasteric reflex is very active. You know, the cremasteric reflex is when the scrotum or the upper part of the medial aspect of the thigh skin is stroked. The cremaster contracts. The cremaster, as I was telling you in the anatomy in the earlier part, is poorly, it invests the vas deferens closely. It's in the inguinal canal. So when the cremaster contracts, the testis is pulled up. Because of the exaggerated cremasteric reflex that's present in some boys during childhood, whenever there is straining or lifting some weight or something, the cremaster contracts and the testis is pulled up into the scrotum, from the scrotum into the inguinal canal, and may disappear. It may not be seen in the scrotum. So that is called retractile testis. You should not get confused retractile testis from undescended testis, because retractile testis is normally placed testis which has temporarily drawn into the inguinal canal by the exaggerated cremasteric reflex. So that will be a differential diagnosis for undescended testis. To clearly say that it is undescended testis, we will not be able to bring back the testis into the bottom of the scrotum. See, retractile testis can be brought into the bottom of the scrotum by milking it from its location in the upper part to the bottom of the scrotum, or when the patient is completely relaxed in a warm place, normally it descends into the scrotum. Another differentiating feature between the undescended testis and the retractile testis is the undescended testis, the scrotum is poorly developed. The scrotum is poorly developed in case of undescended testis, but it's not the same with retractile testis because it is a normally intrascrotal structure. In case it is in the inguinal region, the undescended testis is usually palpable. It may be palpable, but not always. So when you cannot find the testis either in the scrotum or you cannot palpate in the inguinal canal, you may have to do imaging investigations like ultrasonography, which may localize canalicular testis. But on the other hand, if the testis is intra-abdominal, then it may not be, even ultrasonography may not visualize, give us clues to its location. So in that case, you may have to do laparoscopy and search for the testis in the intra-abdominal location. Only if you cannot identify testis, even after laparoscopy and ultrasonography, then you call it agenesis or absent testis. So undescended testis, you have to evaluate like that. Many times the undescended testis is missed in the infancy, and they end up coming with some complication like hernia, or I was telling you that torsion, or some pain which draws the attention that the person is having undescended testis. It can present like that in adult also, when it is missed in the identification in the childhood. How do you treat that? The treatment is archaeopexy before the child attains 1 year of age. Why that 1 year? Because after 1 year, even the microscopic changes also will take place irreversibly. So we want to prevent that occurring. So archaeopexy is a surgery where you bring back the testis which is arrested in its descent above, either from the inguinal canal or from the intra-abdominal region, and bring back into the bottom of the scrotum. That's a surgery, and it's called archaeopexy. Let us learn a little about this archaeopexy. See, the main problem is to gain length of the spermatic cord to bring it back into the bottom of the scrotum. So what do you do to lengthen the spermatic cord? There are certain maneuvers which we can do that. So the surgery itself is will be started with an incision over the deep inguinal ring. In the region of the deep inguinal ring, an incision, a transverse incision is given. And underneath, after the skin, there is an external oblique epineurisis which is opened in the line of its fibers and reflected. So inside the inguinal canal, you can see the location of the undescended testis. So now, to lengthen the spermatic cord and then gain length and then bring it back to the scrotum, three things you have to do. First, As I was telling you, there in 90% of cases there is processus vaginalis is persisting. So you separate the processus vaginalis from the cord structures, isolate it and excise it. That gives a little length. And apart from that, even the cremaster, invested cremaster muscle also can be excised and completely and separated from the cord structures. That will give us much more, further length. So there are lateral fibrous bands at the level of internal ring. You can excise these bands which anchor the cord retroperitoneally. So if you excise them, the further length will gain. With all these maneuvers, it is mostly possible to lengthen the spermatic cord so as enable us to reach, bring back the testes into the bottom of the scrotum. So when sufficient length is attained, this spermatic cord, you can put a finger into the empty scrotal pouch from the inguinal incision and make space for the testes with a finger. Then we'll make a subdartos pouch at the bottom of the scrotum. The subdartos pouch is made by incising the skin, and between the skin and the dartos muscle of the scrotum we can make space, and that is a subdartos pouch. So the testis from the inguinal canal can be brought into this pouch, and then the skin can be sutured, and this inguinal canal can be closed in layers. This is how we do orchidopexy in most cases. But sometimes all these lengthening maneuvers which I described may not be sufficient in rare cases if it is higher up, more proximal. In that case, a two-stage surgery also can be done, wherein first you do the surgery lengthen the spermatic cord by all the maneuvers as much as possible, and then keep the testis in that position for 6 months, and then again redo the surgery from that position, again start lengthening and bring it back to the scrotum. There is another surgery also where first you, along with excising the cremaster, the processus vaginalis, and all the lateral bands at the internal ring, you also cut the testicular artery, which tugs mostly the testis much more than the vas. So you also cut the blood supply. So what happens, and then close the wound. So what happens is the now testis, it is devoid of its normal blood supply from the testicular artery. It tries to get blood supply from the artery to the vas. Yes, artery to the vas also to some extent supplies the testis. So it will start depending on its main blood supply from the artery of the vas, which is a branch of the superior vesical artery, which is again a branch of internal iliac artery. So it gets alternate blood supply from that. So after 6 months, when it depends on its blood supply to alternate means, then you can go back and bring it back. This also has to be done in rare cases. Most of our cases which we do in our institutions, we do by the earlier method which we described. We don't have to, we never had the requirement to cut the testicular artery till now. In case the testis already got atrophied and is soft, and it is a post-pubertal patient, then there is no point in keeping the testis in abnormal location. So orchidectomy also can be done in this case. So these are all the things which you should know about undescended testes. But one thing should be told is because the undescended testes will have inherent abnormalities in the development. It is not a normal testis. Even if you do orchidopexy before 1 year of age, it may not restore its fertility and other characteristics completely. Several studies have shown that there is no improvement in their fertility even after you do orchidopexy before 1 year of age. Even its predisposition to malignancy, which is several times higher than the normal people, is not reduced by bringing it back to the scrotum. But at least that definitely helps, because if a scrotal testis is much more accessible for examination, and when seminoma develops there, you will know it early, and so that way it is beneficial that early diagnosis can be done if it is in a scrotal position. So that's the advantage. But otherwise, the incidence of seminoma or reduced fertility are not improved by this orchidopexy. Absent testis. A little bit of absent testis also we will learn today. Even if after laparoscopy and extensive examination with ultrasonography, if you don't see the testis, it is absent testis. Absent testis can be because of agenesis, or it can disappear. See, prenatal ultrasound examination is very common. Many times testis can be identified intra-abdominally in the prenatal period. When we see the testis in the prenatal period and after the birth, there is no testis in the scrotum, and extensive investigations will show you cannot find the testis. So that is called vanishing testis. So the reason for vanishing testis could be because there can be prenatal torsion. Before the baby is born, there can be torsion of the testis, which is arrested at its descent above, and then this torsion robs the testis of its blood supply, and it may silently atrophy or necrose and disappear during the developmental period itself. So that may be, that is one of the reasons proposed for the vanishing testis. Otherwise, agenesis of the testis is very, very rare. So lastly, in today's class, we will learn something about injuries to the testis. Injuries to the testis can occur in a blunt manner, blunt injury, or a penetrating manner. Blunt injury is by far the most common. One particular injury I would like to mention here is the cricket ball injury. Young boys start playing cricket, fond of playing cricket, and if they don't wear the guard, sometimes a cricket ball can hit the testis, and that's very dangerous injury, because deaths can occur not because of the magnitude of injury and rupture and all, just the severe pain itself can cause vagal inhibition, and heart will stop, and the patient, if he is not revived immediately by CPR, fatalities can occur. Many times this occurs, so one has to be careful about it. Young boys, they should wear the guards while playing the cricket. So the injuries can be minor to major. So minor bruises can occur with a mild injury, or there can be extensive disruption of the testicular tissue and then rupture. We see commonly intratesticular hematomas and rupture of the tunica albuginea and causing bleeding into the within the layers of the tunica vaginalis, that is hematocele. The hematocele is a condition where there is accumulation of blood within the two layers of the tunica vaginalis, that is the parietal and visceral layers of the tunica vaginalis. It's called hematocele. This usually occurs when the tunica albuginea gets ruptured and the bleeding accumulates in this. Or it can be simply an intratesticular hematoma. Even if the force of the injury is such that even the hematocele also ruptures and the scrotum also gets injured, so the bleeding can come outside or within the layers of the scrotal skin. It can reach the perineum and the suprapubic area and all those things. There will be extensive ecchymosis. So these are all the various types of injuries which we see when there is a blunt trauma or a penetrating trauma to the scrotum. So we have to image with ultrasound to see and diagnose what sorts of injury has occurred, and always we'll have to, if there is a rupture of the tunica albuginea of the testis, then we have to do scrotal exploration, and then that rupture can be sutured and the hematoma can be drained and the testis can be saved. If it is on the other hand, if there is extensive lacerations and disruption of the testis, then orchidectomy has to be performed and the bleeding has to be controlled by uploading the vessels and all. See, that's how we treat the scrotal injuries. So that ends our today's class. Next class we'll take more scrotal and testicular conditions.